Thank you very much for this nice introduction, and special thanks to organizers and personally to Mignon McCulloch for inviting me to make this presentation for you. I have nothing to disclose according to this presentation. Kэмпас is a first known trade name for alemtuzumab, a monoclonal antibody directed against cell determinant number 52, expressed on majority of lymphocytes, including T and B lymphocytes and natural killer cells. It's used in organ transplantation since 1998, when Roy Kalm, the famous innovator and pioneer in different types of transplantology, published his article in The Lancet on first 30 renal transplant recipients, adult recipients who received Kэмпас induction and further cyclosporin monotherapy. Roy offered a title for the book which is not written yet, but I like this title as everything coming from Roy Kalm, this phrase is full of sense. First of all, why Kэмпас is a valuable compound? First reason is it affects both T and B lymphocytes, famous targets, well-recognized targets for induction therapy. It's only induction agent who affects both T and B lymphocyte. The second point is alemtuzumab or Kэмпас increase the proportion of T regulatory cells, lymphocyte subset which attributed to graft tolerance or graft acceptance. In this nice experiment, in vitro, T lymphocytes of healthy volunteers incubated with alemtuzumab or normal IgG control demonstrate significant increase in proportion on T regulatory cells, more than 10-fold increase after incubation with alemtuzumab. Further, these data were supported by clinical observations in patients with multiple sclerosis. The proportion of T regulatory cells increased in these patients after alemtuzumab therapy as long as 2 years. The second half of this phrase, why Kэмпас is difficult for clinicians to get hold of. First of all, because the company owning the drug doesn't support an idea to use the Kэмпас in organ transplantation. In 2012, the company undertook rebranding. Alemtuzumab received a new name, Lemtrada, new indication, multiple sclerosis, and new price, which turned to be 70 times higher than original drug Kэмпас. This sort of business activity didn't remain unattended from the side of authorities. And after appropriate investigation, both European and American governments obliged the Sanofi company to distribute Kэмпас free of charge all over the world and maintain appropriate infrastructure for delivery of the drug in all countries. Since that began the era of so-called restricted access to Kэмпас. What does it mean? If you want to administer Kэмпас to your patient, you should fill the requesting form for individual patient. After that, your form will pass through review board, and after approval, you will get the Kэмпас. What's wrong in this process? First of all, it makes impossible a patient randomization. The second point, it's time-consuming. In my country, it takes approximately 2 months. Regardless restricted access, several randomized trial was performed before 2012. The largest of this trial was published in 2011 in New England Journal of Medicine by Michael Hanaway. More than 500 recipients were involved in this study. They were stratified to low and high immunological risk patients. Low-risk patients were randomized on Simulect or Kэмпас. High-risk recipients were randomized on thymoglobulin or Kэмпас. The results show better presentation of alemtuzumab in terms of biopsy-confirmed acute rejection. In low-risk recipients, less rejection observed after Kэмпас induction in comparison with Simulect. In high-risk recipients, similar efficacy observed between Kэмпас and thymoglobulin. Composite endpoint called in this study efficacy failure consisted of graft survival, patient survival, acute rejection, and loss for follow-up. showed the similar results. In low-risk Kэмpas was better than Simulect, and high-risk recipients similar efficacy and excellent safety of both Kэмpas and thymoglobulin. Since 2012, no more randomized trial possible on Kэмpas, but we have a growing volume of registry data. According to OPTN database, fixed on March 22 this year, so it's very recent data, approximately months ago, we can see the rate of different induction agent use in different organ transplantation. In heart transplantation, most popular agent is thymoglobulin. Kэмpas is used very rarely. Probably this is a big mistake, because soon I will show you the benefit in graft survival in deceased donor kidney transplantation. In liver transplantation, similar picture. The most popular strategy is no induction, probably because of immunotolerogenic effect of liver graft. In kidney transplantation, Kэмpas is used in increasing volume since 2004, and after 2008, during decade, the Kэмpas usage ranged between 10 and 20% of all inductions in kidney transplantation in North America. Survival data. In living donor, survival rate, 5-year survival rate, is merely equal in all induction regimen used. In deceased donor, we see a significant increase in 5-year graft survival in patients who received Kэмpas induction. Probably, as always, registry data are confusing. First of all, this is not randomized patient. And secondly, we can suggest that transplant centers using Kэмpas off-label more likely belongs to academician or university societies and probably have more experience, medical experience. And this could explain better survival in Kэмpas patients. I don't know what the real reasons, but we can hardly ignore the fact that 359 American children who received Kэмpas induction and deceased donor kidney transplantation doing significantly better than those who received other kind of induction, especially those who received a thymoglobulin. Russian experience. We use Kэмpas since 2006, performed since during these 12 years approximately 300 kidney transplants on Kэмpas induction. We use 2 doses of Kэмpas subcutaneously, 1 milligram per kilo, not less than 10 and not more than 30 milligram. In deceased donor kidney transplantation, first dose is given on day 0 as early as possible, and the second dose on day 4. In living donor kidney transplantation, we use it by a regional way, not the same as in America. Probably thanks to this regimen, we can achieve survival benefits in living donor kidney transplantation as well. First dose of alemtuzumab is given 2 to 3 weeks prior to kidney transplantation, and second dose on day 0. Survival. In living donor, we have 81% 5-year graft survival and 77% in deceased donor. When compared to registry data, we have a significant benefit in deceased donor kidney transplantation and a slightly less benefit in live donor kidney transplantation. In contrast to American data, where survival benefits were achieved only in deceased donor kidney transplantation. Additional benefits were achieved when we used intensive vaccination protocol and performed transplantation after vaccination complete. 5-year graft survival, 90%. The first lesson we learned during the decade of Kэмpas experience is that the maintenance immunosuppression in Kэмpas patients should be multi-drug. This paletra of different maintenance immunosuppression was fixed in first 100 renal allograft recipients received Kэмpas induction, approximately 8 years post-transplantation. 84 patients remain steroid-free at these times. Tacrolimus TAF level is 2 to 8, wide range and low dose. It is important for my country. I will tell you why a little bit later. We learned that Kэмpas-induced leukopenia should not be a reason for discontinuation or decrease in mycophenolate dosage. patients should receive a proper dose of mycophenolate, and 10% of them will demand GSF to stimulate leukocytes. Majority of these patients, of these 10% of patients, will require only single dose, single shot of GSF. Why we are so happy with Kэмпас in Russia? We know excellent example of kidney graft survival in different part of Europe. In Finland, we know the practice with 90% 10-year graft survival on cyclosporin and azathioprine and steroids. In south of Europe, in Italy, in Bambino Gesù, we know as well 90% 10-year graft survival on tacrolimus steroids and mycophenolate. But both these practices are based on excellent medical infrastructure and sophisticated pediatric nephrology services. Not everywhere in the world these conditions are available. In my country, we have a region in east and north where any medication changes must be approved by a local shaman. This shaman is quite a smart guy. He's well educated and he always supports our medications. But sometimes we can wait his coming back, his return from meditation or other kind of trips for a month. It's time consuming, and we cannot follow the narrow tacrolimus target level in this situation. Another piece of wild nature, virgin nature, with very low density population. Also, we have a transplant recipients here. And in this region, tacrolimus concentration available only 4 times per year. And we obtain the results of the blood test several weeks after sampling. Also, it's difficult to follow the narrow tacrolimus trough level. With our large, wide, and low dose target concentration, we achieve very low rejection rate during 2 years of observation. On tacrolimus, we have less than 10% of clinical rejections, dotted green line, and less than 15% of all rejections, including subclinical ones. And the last lesson we learned in Kэмпас experience is the fact that children who didn't receive steroids in their maintenance are more sensitive to newly administered steroids. What's the practical application of this knowledge? The most practical is community-acquired infection. When the child attending some educational activity or some fest become febrile, quite a usual practice. We stop maintenance mycophenolate in tacrolimus, start steroids, 3 to 5 tablets depending on body dimensions, and after approximately 1 week, when the child recovers, return his maintenance mycophenolate in tacrolimus. What is important additional benefit in this approach? We can freely use macrolides antibiotics in this situation, because usually we are trying to avoid this because of known metabolic interactions between tacrolimus and macrolides. But here, when we can discontinue tacrolimus and with prednisone, which effectively prevent rejection and help us to fight with hyperthermia, we can use macrolides, this effective range of antibiotics freely. Don't worry about tacrolimus concentration. That's all I wanted to share with you with our experience with Kэмпас. Thank you very much for your attention.
I just want to start off by congratulating you, Nadia, and your team for the amazing work you do. I was going to do that before you put up your pictures of your challenges, and when I think I've got challenges, I'm going to remember you have similar but different challenges as well.
Thank you.
Time for questions. Ron.
Very nice job, as always. This very last slide I find confusing. You have a patient 1,000 miles away who gets sick at some distant point after a transplant without access to levels. And you stop the immunosuppression for how long?
Suspend immunosuppression, you mean?
For how long? For how long?
For
do you
1
stop?
week. For
1 week.
For 1 week, you cover
mean-
with steroids, then you resume immunosuppression, and you walk away from this?
Suspend, but we give steroids. Suspend mycophenolate and tacrolimus and provide steroids. And originally, we were worried about rejection. But after a few cases, we understood and recognized that newly administered prednisone in the child who didn't receive it for years, it's highly effective for temperature, for rejection control, and help child to fight an infection.
And how many patients have you done this in?
This regimen, I would say approximately 15 per year. We have around 300 campus patients under our control and approximately 1,000 patients on other kinds of immunosuppression. 15 cases per year approximately.
So you have 100 or so patients like this?
We didn't lost any graft on this approach.
Okay.
I didn't lost any patient. Yeah.
Can I just ask quickly, seeing as this is meant to be an interactive workshop, can I just ask who stops MMF when a patient is not just infected but septic? Anybody in this room?
Stop
Okay. Stopping MMF and FK or TACRO? A little bit more nervous about that. So it's just interesting to see variations in practice.
In one of your first few slides, you talked about tolerance propay by Roy Kahn. Have you ever been tempted to use that, so campath induction with kind of TAC monotherapy, which actually some adult centers, they still do that actually? So campath induction plus TAC monotherapy, have you got any experience?
Without any steroids, JJ, is that what you're saying? So
I'm not sure whether they use steroids or not, to be honest.
just TAC and, sorry, and I know that Oxford does that. Oxford does campath and TACRO, but no MMF.
I think Ron has published a paper
it
on
was,
this as well.
Ron
wasn't it?
experience, yes, from
Yeah.
Pittsburgh.
Sharon may have a comment about that.
Ron, I think it's a question rather to you than to me. The campus tacrolimus monotherapy after campus induction in children. Yes.
You're going to have to stand up, Ron.
In a previous life, we did that. It's been a long time. And I actually converted, before I left Pittsburgh, I converted to dual drug therapy with campath. And in the end, it was just in the pediatric patients. It was a combination tacrolimus and MMF, but with no steroids post-transplant.
Right. Sharon?
Sharon Bartosh, Wisconsin. Full disclosure, I've been using campath induction with steroid-free protocol for probably 12, 13 years now. So we have a good feel for how to use this drug. And the comment I wanted to make is regarding what you do with those sick patients who you stop immunosuppression and put them on prednisone for a period of time, and they do tend to do okay. I can't comment about that, but I can comment about what we see in our non-adherent teenagers. It does seem, and I know Michael Summers, if he's in the room, agrees with this, it does seem that the campath induction gives them a little bit of protection from themselves. So they seem to be able to get away with periods of non-adherence that you might not get away with other protocol induction regimens.
Yes,
I mean,
I
that's
agree.
not to say that we're recommending they become adherent, but it's just an observation that we've had over the years.
And Paul Harden, who has a large adolescent group in Oxford, does very similar protocol. So
I agree. Non-adherence is more likely, non-adherence cases had less consequences on the graft function in campus patients than other inductions. But this picture, when we have a sick child, this is an opposite situation. This is not non-adherence. This rather more adherence in this situation, because this is a sick child. The mother who is highly involved in the care of child. We on call every minute, I would say, so this is a very good adherence. So we can monitor situation every month, and I don't show you, but we have a mobile application for our registry, which allow us to follow the patient. Yeah, allow us very closely.
JJ, last comment.
But what's the experience for Kэмpas in rescue therapy? So steroid-resistant rejection, instead of giving ATG, give Kэмpas. Hits NK cells. Perfect.
Yes, it's difficult to answer on your question very shortly. But in brief, in those who received Kэмpas induction, Kэмpas rescue, in case of antibody-mediated rejection or steroid-resistant rejection, the experience is bad. Kэмpas is working badly. In those who received other kind of induction, Kэмpas is working better.
Great. Thank you very much for a very provocative presentation. That was really good.